Assalamu alaikum. This is Hiba Mahmood, EP 1770054, and the topic assigned to me for today's presentation is bronchiolitis. So first of all, what is bronchiolitis? It is a lower respiratory tract infection that primarily affects the bronchioles. The pathophysiology of bronchiolitis begins with an acute infection of the epithelial cells lining the bronchioles within the lungs. As you can see here, there's a healthy bronchiole on the right and a bronchiole that has been affected by bronchiolitis on the left. Over here, there is inflammation and mucus because of which less air can pass through. And because of that, the infant has trouble breathing. The causative agents of bronchiolitis are most commonly viruses, specifically the respiratory syncytial virus, also known as RSV. Apart from that, adenovirus, human metapneumovirus, influenza virus, and parainfluenza viruses can also cause bronchiolitis. There are some bacteria that can also cause bronchiolitis, such as Mycoplasma pneumonia and Chlamydia pneumonia. Viral bronchiolitis is the most common lower respiratory tract infection in infants and children who are 2 years of age and younger. Now, coming to the epidemiology of bronchiolitis, the most common risk factor for hospitalization is age, prematurity, and children who have unrepaired congenital disease, congenital heart disease, and chronic lung disease. Apart from that, children born with airway abnormalities, such as laryngomalacia, tracheomalacia, and cleft lip or palate may need supportive care to manage a bronchiolitis-associated increase in upper airway secretions. Now, coming to the signs and symptoms, the most common symptoms for bronchiolitis include a runny or stuffy nose, coughing, a fever of 100.4 degrees or more, wheezing, or difficulty in breathing. Apart from that, the infant may also show signs of vomiting, irritability, decreased appetite, and changes in breathing pattern. Doctors are able to diagnose bronchiolitis using a stethoscope, but in case of severe bronchiolitis, there are certain tests that can be taken place, for example, a chest x-ray, viral test, or blood tests. So now coming to the case study with SOAP notes. The clinical presentation that I have here is a 3-month-old male born at 31 weeks of gestation, is admitted for poor feeding and respiratory distress. Envy's mother relates that the infant had been fussy for the past 2 days, had a runny nose, and was stopping feeds prematurely and tiring. His respiration had gone from panting to grunting over the last 12 hours, and he was turning blue around the mouth. His temperature was 101 degree Fahrenheit, with a respiratory rate of 82 breaths per minute and a heart rate of 180 beats per minute. On physical examination, nasal congestion was seen in one ear, and he had crackles and occasional wheezing bilaterally on the chest auscultation. His tympanic membranes are clear, his oxygen saturation was 88% on the pulse oximeter, and his venous blood gas showed a pH of 7.35, partial pressure of carbon dioxide of 56 millimeters of mercury, and a partial pressure of oxygen of 50 millimeters of mercury. He received a dose of nebulized albuterol, and more wheezing was heard bilaterally. Continuous albuterol was applied, but the oxygen saturation went only to 90%. MV has a WBC of 8,700 per millimeter cube with 42% of neutrophils, 50% lymphocytes, 6% monocytes, and 2% eosinophils. Few atypical lymphocytes were seen on the smear. His CRP was 1.3 milligrams per deciliter. A chest x-ray was obtained. A diagnosis of bronchiolitis was made. The patient was transferred to the pediatric intensive care unit for close monitoring. So starting with the SOAP notes, first of all, we have here the subject, and the subject has a runny nose, is stopping feeds prematurely, is grunting, is turning blue around the mouth, has nasal congestion in one ear, and has crackles and occasional wheezing. The objective, the infant, which is 3 months of age, it has poor feeding and respiratory distress, a temperature of 101 degree Fahrenheit, respiratory rate of 82 breaths per minute, heart rate of 180 beats per minute, oxygen saturation before albuterol application is 88%, and after albuterol application is 90%. Venous blood gas pH is 7.35, partial pressure of carbon dioxide is 56 millimeters of mercury, and partial pressure of oxygen is 50 millimeters of mercury. WBCs of 8,700 per millimeter cube, and CRP was 1.3 milligrams per deciliter. Okay, now coming to the assessment, as mentioned in the case study, the infant was diagnosed with bronchiolitis. Majorly because the infant is taking 82 breaths per minute, which exceeds 70 breaths per minute, which is the margin for severe disease of bronchiolitis. Apart from that, the infant is also showing other signs, for example, trouble in sleeping, difficulties in feeding, and wheezing, nasal flaring, increased intercostal muscle retractions, and cyanosis. So we're going to come to the planning. In case of bronchiolitis, medications are not as useful. We have other treatments or other plans that can be used in order to help the infant who is under bronchiolitis. For example, first of all, we're going to treat cyanosis with the help of oxygen therapy. So supplemental oxygen should be continued for MV if an oxygen saturation of less than 90% is sustained. The oxygen should be discontinued when oxygen saturations are persistently greater or equal to 90%. Once not requiring oxygen for 2 hours, discontinue oxygen saturation monitoring, continue other observations 2 to 4 hourly, and reinstate intermittent oxygen monitoring if deterioration occurs. For poor feeding, we're going to help give nutrition and hydration to the infant via intravenous fluids. And when non-oral hydration is required, nasogastric hydration is the route of choice. It should be kept in mind that nasogastric and IV fluids should be commenced at 2/3 maintenance because of potential for increased ADH secretion. So for temperature, we're going to give the infant an antipyretic, preferably called POL. The dose here is 2.5 milliliters up to 4 times in 24 hours. For runny nose and nasal congestion, we're going to give an anti-allergy. 0.0625% to 0.125% of phenylephrine, which is the anti-allergy, is going to be given to the infant every 4 to 6 hours. And also, apart from that, nasal suctioning is also applied to keep MV's nasal passage patent. Now, as I've mentioned, medications are not as useful, but if it's absolutely necessary, then the most commonly used medications for bronchiolitis include bronchodilators, corticosteroids, antivirals, and antibacterials. The bronchodilator albuterol was used in this case, and it was not showing any significant benefit, therefore it was stopped. Corticosteroids in MV must be predicted on its clinical course. So MV's worsening wheezing provides justification for early use of methylprednisolone. Therefore, it is not used. In case of antivirals, we use ribavirin, but it is mostly used for patients who are immunocompromised or cardiovascular impaired. It should not be commonly used in infants. And in case of antibacterials, the empiric use of antibacterials is not at all common because concurrent bacterial pneumonia is not an expectation, despite the occasional appearance of pulmonary infiltrates and atelectasis on chest X-ray. So apart from that, they are saying here that otitis media can certainly be caused by RSV, but it can be difficult to differentiate viral from bacterial etiologies. And macrolide antibiotics must have benefits in RSV. Associated bronchiolitis that some speculate might be attributable to their immunomodulatory effects. However, the needed 3-week course of therapy cannot be supported based on present data. Apart from all the medications and therapies that I mentioned earlier, there are certain lifestyle and home remedies changes that can help in coping, help the infant in coping from bronchiolitis. For example, humidifying the air, keeping the child upright, having the child drink a lot of liquids and fluids. We can also try saline nose drops to ease congestion and maintain a smoke-free environment for the infant. Can bronchiolitis be prevented? So there is an injection, which is known as pelivizumab, that can help decrease your baby's chance of getting RSV, the most common cause of bronchiolitis in children under 5 years of age. So pelivizumab is currently recommended only for high-risk infants, including premature infants, aged at birth less than 35 weeks, and infants with chronic lung diseases. So that concludes my presentation. Thank you very much for your time, and I hope you have a nice day ahead.